Hello, good afternoon, good evening, good morning to all of you attending this webinar organized by the SUNI-SEA project. Apologies for starting a bit late, but people are still joining this webinar. We are very happy that many people attend and are able to join us today. So we organized this webinar as a SUNI-SEA project to exchange experiences and to learn from each other, given the present situation that we are recovering from COVID-19 pandemic, and then we need to learn lessons to know how to approach this situation, recovering after the pandemic, and learn lessons for the future. So we have a number of speakers who will talk today and will explain about situations in different projects. And we have people who will give comments and from their perspective mention what they see as important issues to look at. And thereafter, we will also have a possibility to have questions and answers and be able to discuss a bit. Of course, we know the limitations of this webinars, that it is not easy to discuss spontaneously. So there is a chat with possibilities to ask questions and to give comments, and we hope that you will use that opportunity. So for us as SUNI-SEA project, we concentrate on developing interventions in communities for prevention, screening, and early diagnosis of non-communicable diseases. And we work with primary healthcare programs to be able to receive the referred patients and to give them treatment if they have a diagnosis of diabetes or hypertension or another NCDs. So that means that we work closely in communities and in primary healthcare facilities, and we work a lot with people who are in daily life working closely with people at home. So we were affected by many measures that governments have taken to reduce contacts and to reduce the number of public gatherings. So that has affected many of our activities with regard to screening and health education. And also we noticed that many of the health facilities were forced to concentrate on the COVID-19 treatment, and also there were restrictions with regard to treatment for other diseases because that would give too much burden on the health workers. So both in communities and in health facilities, there were limited possibilities to work on NCDs. At the same time, we saw that having NCDs is an important factor in getting complications of COVID. So it underlined the necessity to work on NCDs, but of course we were limited in doing work in that area. So we were affected in our research, but we also were affected in our type of interventions that we planned to measure impact of our work. So that had to lead to alternative actions, trying to look at possibilities to continue our research, but also maybe change our research focus in some areas to see where we could contribute to this fighting the pandemic. So we want to, in this webinar to share some lessons learned, and we want to hear not only from our own project management, but also from other projects, what their experience were, and especially what does it mean for the future? What does it mean for conducting research internationally? What does it mean for our focus of research? And what does it mean for the healthcare system, and especially healthcare system research, this pandemic, and what recommendations could we make to improve our work and to contribute to fighting future pandemics. So we will have two presentations. One from our project here, the SUNI-SEA project, and another one from Africa, where we have some experiences as well with the COVID pandemic, of course. So I would like to give the floor first to Dr. Vitri Widyaningsih, and she will give an explanation on the work that we have been doing in SUNI-SEA and the way they were able to address issues in Indonesia. So Vitri, you are welcome to take the floor and give your presentation.
Thank you, Dr. Jaap, for the introduction to the SUNI-SEA project as well as to our program today. Good afternoon or good morning, everyone. It is an honor to be able to share our experience in the past 2 years conducting the project, SUNI-SEA project that Jaap has mentioned in the pandemic. So today I will share what our team experienced during the past 2 years and how we cope and move forward with the challenges that we have. So I put this title to our meeting today. So it's resilience, flexibility, and communication. And this is a lesson learned from implementation research, SUNI-SEA in the COVID-19 pandemic. So a bit background into the SUNI-SEA project. SUNI-SEA project is, it is actually an acronym for Scaling Up Non-Communicable Disease Intervention in Southeast Asia. So our project is in Vietnam, and then in Myanmar and Indonesia. And what we aim to do with this project is actually to know what type of intervention is working, and then what is cost effective for the intervention, and then how we can scale up the intervention that we have now into a larger level. As for Indonesia, the SUNI-SEA project, we have 3 areas for the retrospective phase in North Sumatra, and then in Central Java, as well as in East Java. And for the prospective phase that we have now for the intervention, we have in Central Java and in East Java. And this is a bit of the timeline of SUNI-SEA. We started in 2019 with retrospective, what we call retrospective. So we're trying to see and analyze the existing intervention in NCD in the 3 countries, including in Indonesia. And then we aim to have baseline assessment in the end of 2020. And then after that, we will have improved intervention or improved scaling up that we plan to do for 2 years. But then what happened is that the COVID-19 hit us in early 2020, and it changed not only the project, it impacted not only the project, but also the healthcare program that we're actually trying to assess and trying to scale up. So there were healthcare disruption, especially because in Indonesia, we're trying to actually evaluate and intervene on programs in the community, what we call post-Bindu. So what we have there at that time, there were several things that we need to consider in the beginning of 2020 when the pandemic hit. there are several things that we need to think about whether we want to pause the research project or we have to continue the research project aside from what already happened. And several things that we need to consider at that time is the safety, and it is not only the safety of our research staff, but also the community, and then how we try to ensure that the research is still valid, even though we need to change some of the, for example, data collection or some of the instrument that we had. And then the ethical consideration as well. So those are the things that we really need to think about when we think about pausing or continuing. And then we also need to think about how the COVID-19, especially in Indonesia, really disrupt healthcare. So particularly for the community activity for 2020 was disrupted, and for some it was paused or postponed, and very limited community activity were conducted. But however, we need to continue. So there were some importance in the project that we do because non-communicable disease is increasing, and with NCD we have comorbidity with other disease. And then we have the stakeholders that initially we already have communication with that we need to think about as well as the sponsors. So in our project, what we did was we do a simultaneous cycle. We're analyzing what the current situation and then trying to identify challenges and facilitators. And then we prioritize on things that we need to do first. And this is based on the current situation, and then trying to find alternative solution. And all of this we need to communicate and disseminate with our stakeholders. And this is not only local stakeholders, but also consortium members and also our sponsors. And this, we continue to do this routinely, so continuously throughout the project. So how we move forward, and I will share with you how, because the pandemic hit us in the preparation for the implementation and baseline survey. So there were the preparation that needs to be adapted, and then the baseline intervention, as well as the monitoring evaluation. So for preparation, we were in the process of analyzing and disseminate the retrospective phase findings. So at that time, we have safety and health measures for staff as well as stakeholders. So when we can adjust the meeting to online, we will do that. But if not, there will be some health measures that we have in place to ensure that the staff as well as the stakeholder are actually have reduced risk for COVID-19 transmission. And then there were also, we need to extend the period of analysis and planning because we have some additional adjustment that we need to have both in the data collection itself and also the intervention. So some of the adjustment that we had, for example, is inclusion of COVID-19 related precautions. For example, personal protective equipment, and then how we conduct the meeting, whether people needs to have their antigen swab or PCR examination. So those are the things that we actually put in place, and it has to be connected as well with the budgeting as well as with the administrative process. As well as we also have to include some of COVID-19 indicators in the data collection as well, because we know that COVID-19 pandemic hits the healthcare as well, including healthcare in the community related to NCD. So we had several plans and alternatives. And again, we do the analyze and then evaluate and try to come up with the best possible solution for that time. And in each of these steps, we have communication and dissemination with stakeholders. And these include stakeholders in locally as well as in the consortium. So we have regular meetings. In the beginning, we have 2 to 3 weeks per 2 to 3 weeks meeting with the stakeholders, including the consortium member. And we also need to involve the local network to obtain permit and early coordination. As for data collection, it was also slightly changed, but we have to ensure that the data was still valid. So, for example, in recruitment of enumerator, we really involve our network, and then we do it online, and we ensure that all enumerators would actually have vaccination. And at that time, we have to work with the local stakeholders to ensure that the enumerators are actually vaccinated. And then enumerator training was conducted in online session with videos for skills and with safety and health measures as well. As for data collection, we have online and offline supervision. We have daily data cleaning, and we ensure that we have inter-rater validity. So in some area, both the enumerator and the research team actually do the data collection, and we compare the findings. As for the intervention, there were also changes. One of our main intervention is in training. So blended training was implemented. We have videos before we actually meet with the cadres, and we have health protocols. So the number of participants was reduced, and location as well as procedures for the training was also implemented. And then for the intervention itself, we have very close coordination with the stakeholders, weekly supervision with group coordinator, and with the limited time of intervention, because initially we aim for 2 years, but now it's only 1 year, we have more proximal indicators that in place. And same thing happened to monitoring and evaluation. So inclusion of factors affecting implementation is also included. So based on our experience, the 3 main points that we want to share is that conducting research in the time of uncertainty that we had in the past 2 years, we need resilience, so continuous analysis, and then trying to adapt. However, we need to also ensure validity and ethics of the research. And we need to be flexible, so prepare alternative plans, and then move forwards with the best possible alternative, and then communicate and disseminate. That's also one of the things that we think important in the implementation research that we have. So to wrap up this presentation, I'd like to acknowledge my team member. So we have the Indonesian research team and project assistants, the district health departments, primary healthcare, and cadres that have supported us, and also the funding, the European Horizon 2020, and also the SUNI-SEA project consortium. Thank you very much, and the time is back to you. Yeah, thank you.
Thank you very much, Vitri, for this very concise and clear presentation. I don't see questions yet in the chat, but I would invite the participants, if they have direct questions to Vitri, to mention that in the chat. And also, if you have points for discussion that you want to raise, please put them in the chat. So the next speaker is Christopher Pell. He's not on the list of our webinar, but he's replacing Dr. Fortunata Shabalala, and he will introduce himself and explain the project and activities that have been implemented in his area. Welcome, Christopher, to this webinar, and thank you for being available at a short notice.
Hi, Jaap. Hi, everyone. Yes, no problem. I bring apologies from Dr. Shabalala. So in Eswatini, there is some civil unrest at the moment. It's on multiple fronts, but the internet is disconnected in Eswatini today, and so she contacted me via WhatsApp. The Wi-Fi is disconnected. At least she has 3G, so she contacted me via WhatsApp to say she wasn't able to make it. She would have been the ideal person to present, based at the University of Eswatini, and she's been dealing directly with some of the implementation challenges that they've been experiencing the last couple of years. So I'm apologies that you don't have the benefit of her insights and a direct experience. As Jaap said, my name's Christopher Pell. I'm a social scientist based at the Amsterdam Institute for Global Health and Development. And I work quite closely with with Dr. Sebelas and her team on this project, assisting with things like data analysis and the overall design of the study. Now I will share my screen. So the implication of Dr. Sebelas not being able to attend and me having to take over is I had a suspicion yesterday evening that she might not be able to join, so I started making a PowerPoint yesterday. So you have to forgive me that it's quite rudimentary. Let me quickly find it here, and I will share my screen. So I've let me put this on. Okay, you should be able to see that. Okay, let me know if not. Okay, the silence suggests that it's.
You can see it very well.
That it's working. So yeah, so this is another Horizon 2020 project. So also I think started in 2019. So it must have been the same sort of round of project sconsortia that were funded. And this study focuses on Eswatini, formerly known as Swaziland, and we have a consortium of Eswatini-based partners and European partners as well, and also the Clinton Health. The CHAI is the Eswatini based branch of CHAI. So I'm going to talk about the implementation research challenges that were particularly the University of Eswatini team faced, and also slightly broader. So I'd originally, when I started writing my PowerPoint, focused it quite specifically on the sort of the acceptability and implementation work package within this project, but I'll try to widen it out a little bit into the wider project as well. So yeah, the project is WUPEN at scale. We don't have a nice website, but I thought, why is it not going on to the next slide? Oh, there we go. Okay, so I quickly realized that I should put a map up of Eswatini, because not everyone might know where Eswatini is. Like I said, formerly known as Swaziland, so Southern Africa, landlocked with border of Mozambique and most of the country sort of inside South Africa, with which it obviously has very strong relations, a lot of cross-border migration, etc. Population of Eswatini is about a million, and it's one of the world's few absolute monarchies. As you can see, Eswatini, as across many parts of Southern Africa, is going through somewhat of an epidemiological transition, with non-communicable diseases increasing, as well as still having a high burden of communicable diseases, including what was a couple of years ago the highest adult prevalence of HIV. So yeah, they're now 29% roughly. Well, this is from 2017. 29% of deaths are linked to NCDs. So that's the briefest of background, just to locate what I'm talking about, or where I'm talking about. And the WUPEN at scale project. So this is, like I said, the Horizon 2020, and this is specifically on decentralizing. So taking the WUPEN, so the package of interventions for non-communicable diseases developed by the WHO, and trying to implement them across Eswatini, across a population of 1 million. And this was drawing on a previous sort of pilot that was done in one area of Eswatini, which I think finished up, I'm not entirely sure, I guess about 2017 it would have finished up. And the idea was to take, working very closely with the Ministry of Health in Eswatini, who do so this, yeah, so I have to be careful, because there's been lots of changes in this project, which I'm going to touch on. I'm not going to talk about everything. So that this was the original plan of the WUPEN at Scale project, was to take the WUPEN and to scale it up across the country, and basically do this in a randomized manner. So this was going to be one arm of a trial with a standard of care arm, and then other slight adjustments to the WUPEN package. And then there was going to be multiple phases of sort of implementation, with several household surveys to assess the impact of the WUPEN, the package, and also the slight adjustments to the package. Yeah, I think so. Originally we had 3 phases. And accompanying this, so inevitably we had 2 household surveys across these 3 phases at the end of phase 1 and end of phase 2. There was also going to be some economic assessment, both in the facilities of time and motion, as well as from the household surveys as well, around things like care seeking. We also had, and what I'm particularly involved in and was going to talk mainly about today, was mixed methods implementation research, looking at the practicalities of implementing WUPEN in primary care facilities largely, and acceptability amongst the clients and the staff delivering the package. And then we also have a work package on trying to identify potential syndemics, taking advantage of the big household survey, and then also following up that with qualitative work, looking at sort of life history interviews to identify mechanisms of syndemics. So that was sort of, was the original plan. So this is a little bit more of a background again, going back to the state of how NCD hypertension diabetes care was delivered pre-COVID and the start of this project. So this was delivered completely in tertiary facilities, and there was relatively how many hospitals were providing hypertension and diabetes care. I don't know off the top of my head, but it was certainly single figures, the number of places where, so I think it might have been 7 across the country, a country of 1 million. So there's very few entry points, screening, diagnosis and management, and was hospital based. And the idea was to move NCD, hypertension diabetes care, into primary care facilities, and have it largely nurse-based assessment and management. So this is sort of the WUPEN. This was to be, if you like, the intervention arm 1 of this randomized control trial. This was what we proposed. Now things changed somewhat. So there was an additional arm as well, which involved using, so this was, if you like, intervention arm 1, the intervention arm 2, which was going to be involving a cadre of community health workers who would be basically doing demand creation and would be doing screening in communities as well. So that was kind of going to be our phase 1, arms 1 and 2, with the standard of care staying in tertiary facilities. However, when COVID hit, things began to change quite significantly. So what the Ministry of Health in Eswatini decided in 2020 was to instigate expedited process of decentralization, which basically meant doing it ahead of this project, Why? Well, there was obviously the projected burden of COVID-19 in tertiary facilities, and because they recognized NCD clients as high risk of severe COVID disease and wanted them, tried to keep them away as much as possible from tertiary facilities that might, where infection was at high risk, where there was a high risk of infection. So they basically quickly put a relatively quickly put a plan together to implement what was the kind of the intervention arm 1, to implement that across the whole country in a sort of 6 months to 9 months time period, and this meant doing very quick training for nurses in all of the facilities. So they had kind of a mentoring team that went around each of the areas and did trainings, not directly in all of the facilities. It's kind of central locations, and basically put out a guideline, very quickly put out a tool that staff could use, updated the guideline for screening and management. And I mean, I'm already moving. So in terms of what we were doing, I was going to move on to that in a second, but this kind of expedited decentralization was somewhat piecemeal, and was done with somewhat uncertainty, largely because of the speed at which they had to try to train the nursing to all nurses. The other issues were around, so one of in addition to wanting clients to not attend regularly the tertiary facilities, they also did their best to keep clients away from primary facilities. So there was issues, there were large prescriptions were increased to give clients a longer term supply of medication, 3 to 6 months, but they were obviously there wasn't necessarily the medication available for them to be able to do that, and that also led to clients visiting more private facilities and seeking the medication in other locations. There were also, because of the expedited nature of the decentralization, there wasn't necessarily the supplies available, disposables, things like blood pressure cuffs. They weren't necessarily available in the facilities as they would have liked. In terms of kind of practical implications for the implementation research, so a lot of there were obviously several rounds of lockdowns in Eswatini, and this meant that the implementation research, the mixed method implementation research, which included interviews with clients, included interviews with healthcare staff, and observations of how care was to be delivered. So obviously we continued with this. This was originally would have been within the intervention arm, and then sort of switched it to what was now standard of care, or was intended to be standard of care in all facilities. And some of the particularly challenges was some of the a lot of interviews ended up having to be conducted via WhatsApp. So that particularly with healthcare providers, and given the issues with connectivity, that was challenging, not impossible. In the end, that worked out quite well. And just getting used to doing interviews in this in this manner, and I think patience on the part of the local research staff, interviewers, having to deal with multiple breaks in connection. Obviously, that it did have some implications for the quality of the interviews, but having seen the transcripts, I know that in the end there was some interest. There was still very useful insights that came out of these interviews. Other issues because of this low client volume of facilities, because people were actively avoiding facilities, and because of these longer term prescriptions that people were offered, and that this, yeah, when the research staff were able to go to facilities to try to recruit clients to do interviews, that was obviously was presented another challenge, that they had to basically spend a lot more time in facilities to recruit people, and had to coordinate quite closely with the staff to get a sense of when people were coming and when would they be able to recruit them. Obviously, the plan to do observations of care were affected because there were fewer sort of care interactions happening, fewer care processes, and that obviously just required more time on the part of the researchers to be present in the facilities. Also, I mean, we're trying to study this implementation, but always having to recognize that the implementation was conducted in pretty extraordinary circumstances, linked to its the speed at which they tried to roll out originally what was intended to be a much more planned process over a much longer period of time. That the pressures that staff were under, both because of this expedited process and also because of dealing with COVID as well, and inevitably this there were budget constraints that because of this expedited nature that and also because of having to deal with COVID as well. And of course, for all of us, we're trying to come to terms with what is the impact of COVID on the implementation, but also much wider implications of COVID for the research, and also in terms of the health of the population in general. So I mean, I just tried to come up with some wider challenges, thinking beyond the implementation research work package. So just to give you a sense of how much we've, as a consortium, had to adapt the whole approach. So obviously the intervention, what would have been the main sort of intervention arm, albeit with a slightly tweaked second intervention arm, now has become the standard of care. And we've had to come up with essentially new intervention arms, which well, they've already been they've already been implemented the last few months, but they're based around community-based medication and increasing the role of the rural health motivators. So this is a cadre of community health workers, which is actually not the cadre that we were originally going to work with. That changed slightly, so we had to adapt that, the approach there. And yeah, so originally I mentioned, I think at the start, that there were supposed to be multiple phases to this this project, with 3 phases with 2 household surveys. And because of all these delays and having to readjust the whole project in terms of the intervention arms, because of the fact that the household surveys couldn't be conducted, that we now have 2 phases and 1 household survey. So there's quite significant changes to the project, and obviously this had big implications, and we've had lots and lots of discussions with the European Commission, and have had to make an amendment to our grant agreement, which has I don't think quite been accepted yet, but we're almost there. So yeah, this is a European Commission funded project, so I should also acknowledge the role of the Commission in funding that us. I should also, so obviously Dr. Fortunate, I mean, you can see there's a whole range of partners here, from the University of Eswatini, the Clinton Health Access, and the coordinator is based in the Heidelberg in Germany, but we also have Swiss TPH on board as well. Yeah, okay, I have to wrap up. Sorry, yes. So that's my story. Like I said, apologies, Dr. Fortunate wasn't here to present, but I'm happy to take questions as well. Thanks a lot.
Okay, thank you very much, Christopher. I think you gave a very good insight in the way the COVID affected the project, and the way you had also to show flexibility in the way you could approach this project. Of course, it was much more affected, I think, than the SUNI-SEA project, where mainly delays were taking place in Indonesia, but not so much a need to really redefine the project. It's interesting that your intervention arm already became the national policy so quickly, so that is already an instant success for your project, maybe. But of course, it is very important to know, if you work with health services, and when they are affected by this pandemic, that has a huge impact on the project. But it is good to hear your flexibility as well. So for the next round, we will have 3 commenters who will, from their perspective and their experiences, reflect on the presentations and give their own insights. That's Bindu Patel from India, and then Edward Kamau and Bandurek. Let me start with inviting Bindu Patel to give her views on how COVID affected NCD research, but also what's more important, what are the lessons learned, and how should we move on from here with NCD research. Welcome, Bindu. You're still muted.
Sorry about that. Thank you for the introductions. Very interesting projects, Dr. Vitri and Dr. Christopher. I also work with the WHO Pen package in Fiji, which they implemented in 2012. And we had a steering committee meeting in December of 2019 in Fiji to design the evaluation, because they haven't done an evaluation, and they have a large epidemic of high prevalence of chronic disease, and it's increasing. But with COVID, we were about to go in March, and it was put on hold. Obviously, all the ministries of health and heads had other priorities, but we had, a couple of key stakeholders, WHO technical officers, that were able to respond to queries, but it's taken 2 years. Now we finally are taken off and submitting to ethics. But my questions to you, Dr. Vitri, first would be, which I found was really interesting, that there was a lot of commitment, it seemed like, from local stakeholders to continuously adapt your intervention and meet, which I find to be unique. Is it Indonesian specific context, or do you think it was similar in Myanmar, as in Indonesia, as in Vietnam? Like, what were the differences in you continuously adapting your intervention and having that commitment for stakeholders to meet with you 2 to 3 times a month? So that was my first question.
Yeah, should I respond now, or okay, I'll just respond
Yes,
now.
I think that is better to respond now, because then we don't forget the question.
Right. Thank you very much, Dr. Bindu Patel. Regarding the questions, unfortunately, we cannot really learn about Myanmar, because with the civil unrest there, the project has been postponed. But with Vietnam, I think we see similarities. So we have close coordination with the local stakeholder. We are contacting the local stakeholder as well about the local policy. So in Indonesia, the local policy on COVID-19 changed, so evaluated every 2 weeks. So that's why in the height of COVID-19, we actually meet with the local stakeholder every 2 weeks to actually assess. However, when the COVID-19 situation has already winding down, it's better. The meeting is not so frequent, so we're not meeting every 2 weeks, but only in the beginning or as right now, we also see increase in COVID-19 cases in Indonesia. So we meet or coordinate or communicate with them regularly. So it's not always a meeting per se, but sometimes we communicate and have feedback from them. And we think it's because in some of the area, we have local network, so that's really helpful. So we have, for example, students from our postgraduate program working in the area, and that's really helpful in providing platform for us to coordinate and disseminate. Yeah, thank you very much for your questions.
Yeah, that was great. And I had one other question, is that you pivoted from your original design and you adapted it for a shorter time frame. Have you adapted the theory of change in your intended outcomes? Because you said that it was more immediate indicators. So how do you think that's going to affect your overall research? In retrospectively, you've measured, the prevalence and what works and not works, but when you're implementing the intervention and scaling it up, how do you think that will affect it on the ground?
Yeah, thank you. As for the theory of change, we still have the similar path. However, the indicators is actually changing. So, for example, now we are focusing more on knowledge, attitude, practice, not so much on the health outcomes, but on how the behavior changes. As for the implementation outcomes, we are also looking at how people are adapting, the cadres are adapting with the intervention that we are conducting. So we are really looking at more proximal process evaluation and indicators that we can actually have within 1 year instead of the initial 2 years that we planned.
Thank you, Dr. Vitri. Thank you.
But maybe, Dr. Patel, you could also give some views on what you think that it means for future research in NCDs, the lessons learned from this COVID pandemic.
So from my perspective is that for future research in low middle income countries is needing that trust and network, as Dr. Vitri said, on the ground, having that built up ahead of time so that it can continue on and can be adapted. We were, from my experience, if you don't have that initially, it takes time to actually contact and for that person to respond to you, and trust builds over time. So having, number one, I would think the trust and common agenda for the local stakeholders and different sectors to be committed from the beginning before an urgent, a pandemic occurs.
Okay, thank you. I think that are very important points you raise. And as this research, both in Vietnam and Indonesia, is building on existing programs to improve them and expand them, that trust building was already part of the preparation. So that's maybe why in Indonesia they were able to communicate very closely with the stakeholders on a frequent basis to discuss the situation and what is possible or not. So some things could happen even when maybe measures were still in place, and especially the blended activities helped a lot in also the trust of the local stakeholders that we were taking the right measures to protect the population from being infected. Okay, can I maybe move to the next reviewer and the next commenter? Edward Kamau, maybe you can introduce yourself and give your views on this situation and research. Welcome.
Good morning, colleagues. Thank you, Jaap, for the invitation and also for SUNI-SEA for organizing this webinar. My name's Kamau Edward. I work with TDR as a technical officer with capacity strengthening unit, whereby in the last 10 or so years, the main occupation has been capacity strengthening, focusing on infectious diseases of poverty and not NCDs, but today we have converted to both. Anyway, jokes aside, the point is that we have been providing kinds of resources for training, both individual and institutional. And I think my association with SUNI is based on the fact that SEA was one of the initial people when we were developing our online toolkit, implementation research toolkit that is available for free download and use. And we have been in the recent past adopting as everybody else to the special situations brought about by COVID. As TDR, COVID just multiplied what we have been experiencing in small doses for a long time. We work in mainly about maybe most of our work, 90% is in developing countries, and we have many COVID-like situations in terms of what our colleague just mentioned here, Christopher, that made our colleague not being able to join in the presentation. And this has already prepared TDR in terms of thinking ahead in terms of what do you do when things don't work normally. And they do quite often happen on small scales. And one of the things we have been adapting for a long time, our training resources, of course, it starts off with the hard copies, electronics, and now we have several platforms that we are delivering the same. The question that we have always asked ourselves, and I think the first presenter did highlight this very clearly, do we continue? If we do, what are the legal and ethical implications of us stopping or changing the protocol? And some of the solutions that we have been always trying to propose is to build the capacity for implementation research within the programs, so that despite what circumstances occur, so long as the program is there, they might slow down, but they are the one running the show. So they will be able to continue within a local setting what they have been doing all along, because the program will always be there. There might be hiccups, small ones, big ones, but so long as the capacity is within the institution, the programs, or closely related stakeholders within the country, then data collection and all other activities that are concerned with the implementation integrity of the programs, it will continue. There might be things that will not happen as planned, but when they rely on outside support, things will definitely not continue in most cases. And we have had situations whereby projects are suspended or stopped altogether without regard for any ethical or legal implications of what's going on. So, and I would like, I would have liked to, I didn't know that there were some issues already in Eswatini, but I would have liked to get some feel of what it means for researchers, for example, our colleague in Eswatini, to work within a very difficult situations, in addition to the COVID-19. This is what I'm talking about. So it's a mini disaster within a big disaster. So I think we need to give cognizance to work that is being done by our colleagues in very difficult situations. And I think, Christopher, if you have any kind of insight. You promise that you don't have all the insights, but what kind of issues arose when our colleagues don't have enough time to do this kind of thing, and they are faced by unprecedented situations that nobody anticipated, but life has to go on. Yes, Christopher.
Yeah, so I mean, this obviously, not been able to travel to Eswatini, so I haven't been able to travel, although I actually do plan to go at the end of this this month, has created a distance. We talk on WhatsApp and Zoom, etc., and try to get a sense of what's happening there. But that's not been able to go has also created a bit of a distance to get a real insight into what's been happening. But I think, I mean, I maybe should have emphasized a bit more that, I mean, it's been quite an achievement. I mean, the Ministry of Health has really moved mountains to make the decentralization happen when it did. And I mean, as I sort of hinted at, there were it might not have been done exactly how they would have done it had they had the time. But I think it's quite an achievement to push that forward in the way that they did. And then this has meant a lot of collaboration between close work. We had a coordinator, who was working with Heidelberg, but someone from Eswatini who was based there, who did a huge amount of work to coordinate this and to make sure that basically the project, the consortium could support the decentralization and was able to continue some implementation research alongside the decentralization, and then to try to feed back lessons that were coming out of the interviews, etc., that the implementation research team were doing. So very close collaboration with the Ministry of Health and the University of Eswatini. But clearly there, COVID has also been compounded with other issues of civil unrest over the last couple of years in Eswatini, and really struggling to keep going, but still managing to get to collect data, do useful and come up with useful insights. So it's really been very impressive to see, albeit from a distance, how they've managed to cope with a very difficult situation, but keep going.
Thank you. Maybe I find it interesting, Edward, that you talk about disasters happening even besides COVID. Well, Vitri already mentioned our project in Myanmar was affected by the military coup, where we could no longer work in communities like we were used to do. But the team there has shifted to many online activities for screening, for health education. Luckily, internet is still working, and small-scale community activities can take place. So with the new technology, we see that whole communities are changing their way of communication, their way of looking at health issues. So it's not only the online training that we introduced for health workers and for researchers, but also for community members, and screening using online tools was introduced and is now being worked out. So that kind of flexibility was there as well. So that is, I think, what is I think important to mention, that you mentioned, Edward, that disasters happen, even if it's not a pandemic. We know that in many projects you have to be flexible, also for other reasons. And any other thing you wanted to mention, Edward, in your reflection?
Yes, I think just to reiterate the fact that you are able to succeed in that setting because you built the capacity within the program or with the partners within the country. And for us, that's a key emphasis on our training, that the engine, the people who do the actual, who ask the questions, especially if it's implementation research. The people who ask the questions are the people within the programs. And therefore, come what may, they will find a way to continue addressing those questions. And of course, just to add that for the last few months, we have had similar cases in West Africa. And as you can imagine, we have so many other projects within that region, and we are facing the same, but it is our still focus. Please build capacity within the systems, and you not be losing anything on that. Thanks.
Okay, thank you. That's a very important insight that we all should take at heart. And luckily enough, both in the project in Eswatini and in our SUNI-SEA project, we work with very strong local partners, both in Vietnam and in Indonesia and in Myanmar as well. So that is always necessary if you do international research, that you don't conduct it from some place in a high income country and don't have a very strong local partner. So I think that's an important lesson that we have also seen, that the flexibility and the trust building, you need to have a very strong local partner in research. I would like to give the floor to Izzy. Izzy is working with GACD, and they are coordinating a lot of these projects. And in our research meetings, we had already heard a lot about the influence of COVID on many of the projects, but Izzy can reflect on that, and maybe she has some concrete questions to one of the two projects as well. Izzy, welcome.
Lovely, thank you so much, Jaap, and thank you again to the organisers for inviting us. As I said, I'm Izzy, and I work for the Global Alliance for Chronic Diseases, and we're a unique alliance of funders, which includes the EU Commission, who you will have heard are funding Christopher and Vitri's wonderful projects. And the alliance of funders that we are come together for three key overlapping areas, and that is NCDs, implementation science, and populations in low and middle income countries. So we've got a real unique overlap between those three areas. And I think one of the things that has been particularly evident during the pandemic is the importance of the network and that cross-project working and sharing of experience. So when the pandemic first hit, GACD organised webinars and surveys of all the projects that are funded through this alliance. So that's over 100 different projects across more than 70 countries in the world, and all at different stages of their research. And to draw together what was going on for them, what were the challenges, and also what were the solutions that they were finding in real time. So I think from our perspective, one of the main perhaps positive things that came out was that reliance on the network and reaching out more and more collaboration. And just to reflect on what the other panelists have said, absolutely building that capacity in the system, having it there means that the great effort can be taken to continue that research, and it wouldn't be possible if there weren't that capacity locally already. I think something of interest to me that I would love to hear reflections from Christopher and from Vitri on is around any practices that they've found that they've done newly now that they would keep for future projects, and any practices that they would just not keep, or perhaps were only relevant for this specific projects. So any shared learning that you can give.
You'd like to start, Christopher, or
We're both going to offer it to one another. You can go. You can go ahead, but I leave it up to you to decide.
Okay, I'll start, and then we can contribute some more. Thank you, Izzy, for the questions. I think one of the thing that we really learned from this project and how we handle the project is how to, first we build trust. That's something that we already established, very important, and then communicate and be truthful actually with the local stakeholders. So we're actually communicating our expectation within the project, for the project, and that, but we also think about how it can be implemented in the field. So we're also thinking about how it will affect the community. And there were some changes that we actually had to do because of the input and feedback from the local stakeholders. But we think that this is something that very important for us, especially because we want this project to sustain and also to be scaled up later after the finalization of the project. So building the trust and actually trying to make the stakeholders become more active participants in our study. That will be something that for us we will continue to in our next project. As for the second questions, for those that we lesson learned that we might want to leave is well, there were some for example, when we had to recruit some local enumerators or local field staff or research staff. Initially we have like open recruitment, and we send out invitation. That's what we initially did, because that's what we usually do when we actually able to come there and actually interview people and do the training. But we learned from our experience that those might we actually need reference, we need recommendations. So instead of having an open recruitment and having people especially with the online recruitment, everybody can actually submit. So we have to do the, it was a very hard to filter most of the things that we need to do. So those are the things that we think we will like to change. So mobilizing and utilizing what we have in the local stakeholders to not only with the research, but also with the project activities. I think that's what we want to do. Thank you.
Christopher, yeah.
So the thought was, so obviously some of the things, for example, doing WhatsApp interviews. So that was a bit of a exceptional sort of approach, and I think that, you know, we kind of took that as a needs must, wanting to try and give, you know, rapid feedback to the Ministry of Health about how implementation was going. I think that definitely has some limitations, and I probably, you know, always would prefer to do those types of interviews in person. So I probably, if possible, would restrict that to, you know, a needs must kind of setup. I think, and you know, also for the way that the training has been done for the actually, you know, the decentralization itself. As we've moved into the intervention arms and the training that's accompanied those, when possible, you know, that's also been switched to more traditional ways. So I think both in terms of sort of how some of the elements that way that research was done, but also how the implementation was done. I think in Eswatini, you know, it was a sort of fairly emergency situation, and they would prefer to do it in a more standard way if possible, with things like in-person meetings and in-person interviews, rather than doing things in a sort of bare bones way. So I think in some ways it emphasized the value of being in the same room, it emphasized the value of you know, and for in more sort of broader engagement as well. That's in a context like Eswatini, where you know, internet access is not the same as maybe in Southeast Asia. That, you know, you can only get so far with these sort of online activities, that there is, you know, where possible, you want to be doing things face to face, both for research, but also for the implementation as well. Yeah, I think that was my sort of reflection on it.
Thank you. Izzy, have other points you would like to raise from experiences?
I think one thing that is worth drawing on here, and it's something that Vitri and Christopher both mentioned around the use or the necessity of using online channels to connect with participants in the research, other stakeholders, and of course that necessity was imposed on people during the pandemic. And one thing that we as GACD did was organise a workshop last year to explore digital health interventions a little bit more closely, with a bit more detail, and actually a colleague of Christopher's did speak at that workshop to share their experiences. And one thing that came up there was around equity of access, which was an ongoing conversation I think that we can all continue to work on, because on the one hand, by putting something online, it potentially reaches more people. You can get more people involved in the project, but on the other hand, the equitable engagement is contingent on a stable internet connection or a suitable device or a smartphone, or having access to 3G or whatever's in that local area. So I think an ongoing conversation for many people working in implementation science is around balancing different levels and different components of equity of access. And I think that's more of a comment than a question, but I'd certainly welcome any reflections that Vitri has from or her personal experience researching, or Christopher does from their WHO Pen at Scale project.
Okay, I'd like to add if there's additional time. Yeah.
Yeah, you can answer quickly because we are running out of time. Yeah.
Yeah, thank you, Izzy. There is actually also something that we have inequitable access to internet. So what in one of our intervention, we actually we have an application for self-screening as well as screening by cadres. But in addition to that, we also have manual screening. We have Excel forms, so that trying to make sure that people who don't have a smartphone or internet access also can have the intervention as well. But that is something very interesting as well that we need to think about in our research. Thank you.
Christopher, you have any addition to access to internet and equity?
Yeah, I mean, I think that's what I was sort of trying to hint at before, that, you know, for lots of the work in Eswatini, that the preference is for currently more traditional ways, face-to-face, rather than taking things online, particularly for when the smartphone access is not what it's the. I should say that the work that's been done sort of in Eswatini, particularly around using smartphones, using tablets, has been for the rural health motivators, for the community health workers. So they are using a tablet-based app for screening. Lots of the work there is not principally for clients themselves to be self-screening by a smartphone. So there's not in this project, there's not so much reliance on digital technologies anyway, but yeah, again, clearly there's a preference for sort of more old school, taking things offline.
Okay, thank you. Izzy, one final word of comment? No?
No, okay. I'm aware of the time. Please do continue.
Yeah, thank you. Well, we heard already being prepared, capacity building, and having strong local partners is important. So we invited Jody Mahendrata to give us a short, maybe presentation on what capacity building is possible there.
Okay, thank you. Yep, so I'm just going to share my screen quickly. Okay, so first of all, thank you for the organizer for having me, for sharing, but also for learning. I'm already learning a lot from the discussions here. So basically, just to introduce myself, my name is Jody Mahendrata. I'm Vice Dean at the Faculty of Medicine, Public Health and Nursing at Gajah Mada University. And we've been working on implementation research for, say, over a decade now, mostly with TDR, with Edward Kamau here, one of our colleagues there. And our mandate is basically capacity building in the Southeast Asia and Western Pacific region. Now, one of the things which I learned from this discussion is that there are a few things which we could pick up to actually move forward with some of the things which we have. So first, we already have what we call core competencies in implementation research, which we formulated, and this was published. You can have a look at it. It's open access. This was in 2019. This was before the pandemic. And it basically tries to set out what are the core competencies in terms of IR. Now, one thing which is not there yet is what we've been discussing in this webinar, which is about how to carry out IR within a conflict setting, within a crisis, within an emergency or pandemic, which is often the case because IR is done in real life situation, in real life setting, and is very dynamic. And so you would expect this kinds of situation would happen quite often. So that's not there. So that's something which we might consider and try also to bring in, that one of the key competencies of IR is how to actually carry it out under a crisis, under a emergency setting, and so forth. Okay, so those are, I think, an important note for further development of the competencies and implementation of research. Now, moving on to more practical terms. So one of the things which we've been engaged in for the past 5 years or so with TDR is organizing this postgraduate training scheme in implementation research. And this is a part of a scheme which involves here, as you can see, 8 universities across the world, and we are one of them. We are here designated for Southeast Asia and Western Pacific, together with colleagues from Bangladesh, from the James P. Grant Public Health. And we have already graduated over 70 students since 2015, and so are also our colleagues in Bangladesh. And we are currently releasing our call for application. So if anybody's actually interested to join this postgraduate training program, feel free to have a look. Our deadline is on April 28th, and you can have a look at the call online also. You can just Google it. I think you can find it quite easily. So you still have quite some time, about a couple of months to actually prepare an application. Or if you have colleagues which you think would benefit from having a postgraduate training implementation research, if he or she comes from Southeast Asia or Western Pacific region. Now, once the students graduate, we don't stop there. We also develop a platform for the alumni so that we can also still facilitate their learning, because IR is continuous learning. So this is our platform, which we call IR Connect, which we facilitate continuous learning for our alumni. And this is an example of a webinar which we had for alumni, which is similar to what we're discussing now. It's about the role of IR for pandemic response in a different perspective. So that's from the postgraduate training scheme. Now, beside carrying out postgraduate programs, we are also a regional training center for TDR for Southeast Asia. And with that, we have the mandate to build capacity for good research practices in Southeast Asia, including on implementation research. And in practice, we carry out TDR trainings for IR. So Eddie, for example, was the lead developer of this IR toolkit, which is fully online, and we organize online workshop, but also hybrid workshop to be able to go through this IR toolkit and produce a proposal, an IR proposal at the end of the toolkit workshop. Another one which we are doing together again with TDR is this massive open online course on implementation research. And this is also going around across different regions of the world, of WHO regions. And for our regions in Southeast Asia, we are planning to start our massive open online course on 29th of March. So that's practically 4 weeks from now. So if you have anybody who you think would benefit from this, or if you would be interested, feel free. It's a massive open online course, so we can handle thousands of participants. And what's interesting with this course is that it doesn't just take you through to develop a proposal, But at the end, if your proposal is good enough, we actually will provide few small grants for you to be able to carry out that proposal and carry out that IR project as part of the learning itself. So I think that's a very quick overview of what's on the table, the menu that we can offer, which is out there, and something that people can actually look up to in the coming few weeks or so. So we're looking forward for you and to join us to build capacity of implementation research in Southeast Asia and Western Pacific. Thank you, Jaap.
Thank you very much, Jordi. Very good to know about this, and of course you had little time, so we will also make this information available on our website so that people can get access to that information, because I think it is very important. As we have only a few minutes left, there is not much time for discussion. There was one question on the disruption of health services, how we deal with that, but I think both Christopher and Vitri gave some indication on how they dealt with it, especially in the flexibility, looking at possibilities to change approach. For the sake of time, I would like to summarize some important points that I picked up from this webinar. And first of all, is be prepared, better preparation for the projects, and of course the capacity building that was mentioned by Jordi is an important preparation, but having strong local partners is a must for developing research in low and middle income countries, because that will give a much more flexibility in the projects, and much more resilience. Edward mentioned, well, disasters happen. If it is not a disaster like the COVID-19, it is on a smaller scale, like we experienced in Eswatini, but also in Myanmar, in the two projects that were examples. So you must build research that is resilient and can cope with local conditions, and therefore having very strong local partners is a must for better research that is more resilient. Flexibility was mentioned by both examples and also by the commenters, that we need to be able to adjust to situations, because even if there is no COVID, we may need to adapt. And of course, for funding agencies, that is often a very difficult point, because they want you to stick to descriptions of action and stick to the research that you have prepared. But there is need to be able to adjust to situations, and funding agencies must think with the researchers on what is the best way to deal with circumstances. In this flexibility, we did see that many used online tools for training, but online tools for meetings and online tools for capacity building of researchers. So there's a lot of possibilities, even at community level, using social media or other online possibilities for interviews or for screening or other activities is an opportunity that we can use more in the future. But there was a clear warning from the speakers that equity of access to internet is still a major issue. So if we want to reach the most vulnerable groups, then we must still use other means of communication and meeting them. The fourth important point is communication and dissemination. The trust was very much mentioned, that you need to have trust with the local stakeholders and the local authorities, and must communicate continuously with them to be able to see where adaptations can be made, but also to see where they can give permission for taking steps in the research and the implementation that are needed. So both projects gave examples on how they worked with local authorities to make adaptations in research. So the trust building should not come at the end of the project, but should be part of the preparation of the project. So their participation in preparation could be an important condition for funding research. And the final point that was also mentioned is that the networking and the collaboration between research projects and learning from each other and maybe using tools that have been developed by others. And I'm very happy to hear from Jody that there are research toolkits that are available. Hopefully they will also include then possibilities for flexible blended learning and for online working. So networking globally among research projects and working together to come with the best possible solutions is an important point that GACD also is moderating. So that is very important. So all in all, I think in this 1.5 hours, we got some very important lessons learned. We definitely will continue to discuss. We hopefully can also continue sharing experiences on how we can tackle these disruptions that occur through pandemics and other causes. But I think it's also important, especially because we are talking about NCDs, that we make more links between NCD research and infectious disease research, because we see that NCDs are an important precondition for vulnerability for infectious diseases. So hopefully we can broaden that perspective as well and not work in silos in different research projects. So the international exchange on lessons learned will continue, and it's very important to continue thinking together on that. So with that, we have come to the end of this webinar. I would especially like to thank very much C and Raji, who have been preparing this and have brought us together. There will be a recording and a report available, and maybe Raji or C, you want to give final information on where further information can be obtained, the presentations and the report that you will be making, and the links to the implementation research training programs. C or Raji, can you maybe open up and speak on that?
Sure, thank you everyone. We will have all the information available on SUNI-SEA website. We will have the link to the website available in the chat, so please visit our website and learn more about SUNI-SEA and also get more information about the discussion today. Thank you.
Okay, with that we close, so we continue the discussion and definitely will produce some report on the learning points from this webinar and maybe see how we can continue the discussion on further improvement of NCD research globally. Thank you all very much and have a good day. Bye-bye.
Thank you. Have a good day.
Thank you. Bye-bye.
Thank you, everyone.
Bye.
Bye-bye.
Thanks very much.
Take care.
Bye everyone. Thank you.